Cholecystitis, um, pages 1366 to 1371. The biliary system, liver and gallbladder, and pancreas secrete enzymes and other substances that promote food digestion in the stomach and small intestine. When these organs do not work properly, the person has impaired digestion, which may result in inadequate nutrition. Interdisciplinary management of patients with problems of the biliary system and pancreas includes the need to promote nutrition for normal cellular function. This chapter focuses on problems of the gallbladder and pancreas. Liver disorders were described in chapter 61. Because of the close anatomic location of these organs, disorders of the gallbladder and pancreas may extend to other organs if the primary health problem is not treated early. Inflammation is caused by obstruction or blockage in the biliary system from gallstones, edema, stricture, or tumors. For example, gallstones in the cystic duct cause cholecystitis or cholecystitis. Gallstones lodged in the ampulla of Vater block the flow of bile and pancreatic secretions, which can result in pancreatitis. Gallbladder disorders. Cholecystitis. Pathophysiology. Cholecystitis is an inflammation of the gallbladder that affects many people, most commonly in affluent countries. It may be either acute or chronic, although most patients have the acute type. Over 500,000 surgeries for this health problem are done in the United States each year. Acute cholecystitis. Two types of acute cholecystitis can occur, calculous and acalculous cholecystitis. The most common type is calculous cholecystitis, in which chemical irritation and inflammation result from gallstones, or also called cholithiasis, that obstruct the cystic duct most often, gallbladder neck, or common bile duct, figure 62.1. When the gallbladder is inflamed, trapped bile is reabsorbed and acts as a chemical irritant to the gallbladder wall. That is, the bile has a toxic effect. Reabsorbed bile is in combination with impaired circulation, edema, and distension of the gallbladder causes ischemia and infection. The result is tissue sloughing and with necrosis and gangrene. The gallbladder wall may eventually perforate or rupture. If the perforation is small and localized, an abscess may form. Peritonitis, infection of the peritoneum, may result if the perforation is large. The exact pathophysiology of gallstone formation is not clearly understood, but abnormal metabolism of cholesterol and bile salts plays an important role in their formation. The gallbladder provides an excellent environment for the production of stones because it only occasionally mixes its normally abundant mucus with its highly viscous concentrated bile. The constant temperature within the gallbladder also contributes to stone formation by delaying bile emptying, causing biliary stasis. Gallstones are composed of substances normally found in bile, such as cholesterol, bilirubin, bile salts, calcium, and various proteins. They are classified as either cholesterol stones or pigment stones. Cholesterol calculi form as a result of metabolic imbalances of cholesterol and bile salts. They are the most common type found in people in the United States. Pigmented stones are associated with cirrhosis of the liver. Bacteria can collect around the stones in the biliary system. Severe bacterial invasion can lead to life-threatening suppurative cholangitis when symptoms are not recognized quickly and pus accumulates in the ductal system. Acalculous cholecystitis inflammation occurring without gallstones is typically associated with biliary stasis caused by any condition that affects the regular filling or emptying of the gallbladder. For example, a decrease in blood flow to the gallbladder or anatomic problems such as twisting or kinking of the gallbladder neck or cystic duct can result in pancreatic enzyme reflux into the gallbladder, causing inflammation. Most cases of this type of cholecystitis occur in patients with sepsis, severe trauma or burns, long-term total parenteral nutrition, multi-system organ failure, major surgery or postoperatively, and hypovolemia. Chronic cholecystitis. Chronic cholecystitis results when repeated episodes of cystic duct obstruction cause chronic inflammation. Calculi are almost always present. In chronic cholecystitis, the gallbladder becomes fibrotic and contracted, which results in decreased motility and deficient absorption. Pancreatitis and cholangitis can occur as chronic complications of cholecystitis. These problems result from the backup of bile throughout the biliary tract. Bile obstruction leads to jaundice. Jaundice, yellow discoloration of the skin and mucous membranes, and icterus, yellow discoloration of the sclerae, can the eye, white part of the eye, can occur in patients with acute cholecystitis, but are most commonly seen in those with the chronic form of the disease. Obstructed bile flow caused by edema of the ducts or gallstones contributes to extrahepatic obstructive jaundice. Jaundice and cholecystitis may also be caused by direct liver involvement. Inflammation of the liver's bile channels or bile ducts may cause intrahepatic obstructive jaundice, resulting in an increase in circulating levels of bilirubin, the major pigment of bile. The brown stuff. When the concentration of bilirubin in the blood increases, jaundice can occur. In a person with obstructive jaundice, the normal flow of bile into the duodenum is blocked, allowing excessive bile salts to accumulate in the skin. This accumulation of bile salts leads to pruritus or itching, or a burning sensation. The bile flow blockage also prevents bilirubin from reaching the large intestine, where it is converted to urobilinogen. Because urobilinogen accounts for the normal brown color of feces, clay-colored stools result. Water-soluble bilirubin is normally excreted by the kidneys in the urine. When an excess of circulating bilirubin occurs, the urine becomes dark and foamy because of the kidney's effort to clear the bilirubin. Etiology and genetic risk. A familial or genetic tendency appears to play a role in the development of cholelithiasis, but this may be partially related to familial nutrition habits, excessive dietary cholesterol intake, and sedentary lifestyles. Gallstones are seen more frequently in obese patients, probably as a result of impaired fat metabolism or increased cholesterol. Age is also a factor, with people older than 60 years being more likely than younger people to develop stones. Patients with diabetes mellitus are also at increased risk because they usually have higher levels of fatty acids or triglycerides. American Indians and Mexican Americans have a higher risk of or higher incidence of the disease than other groups, which may be due to the higher incidence of diabetes among these populations. Other causes are included in Table 62.1. Table 62.1, Risk Factors for Cholecystitis. women, people older than 60 years, American Indian, Mexican American, or Caucasian, obesity, rapid weight loss or prolonged fasting, women on hormone replacement therapy, HRT, or older birth control pills, family history of gallstones, prolonged total parenteral nutrition, Crohn's disease, gastric bypass surgery, sickle cell anemia, and glucose intolerance. Women's health considerations. Women who are between 20 and 60 years of age are twice as likely to develop gallstones as men. Obesity is a major risk factor for gallstone formation, especially in women. Pregnancy tends to worsen gallstone formation. Pregnancy is, as well as drugs such as estrogen and birth control pills, especially the older oral contraceptives, alters hormone levels and delays muscular contraction of the gallbladder, decreasing the rate of bile emptying. The incidence of gallstones is higher in women who have had multiple pregnancies. Combinations of causative factors increase the incidence of stone formation, especially in women. Therefore, some clinicians refer to the patient most at risk for cholecystitis and gallstones by the 4 F's: female, 40, fat, and fertile. Female, fatty, 40, fat, fertile. Fat, 40, female, fertile. Okay, sorry. Patient-centered collaborative care assessment. Physical assessment, clinical manifestations. Patients with acute cholecystitis present with abdominal pain, although clinical manifestations vary in intensity and frequency. Chart 62.1. Obtain the patient's height, weight, and vital signs, or delegate these activities to UAP. Ask about food preferences and determine whether excessive fat and cholesterol are part of the diet. Inquire if any foods cause pain. Question whether any GI symptoms occur when fatty food is eaten: flatulence, dyspepsia, indigestion, eructation, or belching, anorexia, nausea, vomiting, and abdominal pain or discomfort. Ask the patient to describe the pain, including its intensity and duration, precipitating factors, and any measures that relieve it. It may be described as indigestion of varying intensity, ranging from a mild, persistent ache to a steady, constant pain in the right upper abdominal quadrant. It may radiate to the right shoulder or scapula. In some cases, the abdominal pain of chronic cholecystitis may be vague and nonspecific. The usual pattern is episodic. Patients often refer to these episodes as gallbladder attacks. The severe pain of biliary colic, or colic. The severe pain of biliary colic is produced by obstruction of the cystic duct of the gallbladder. When a stone is moving through or is lodged within the duct, tissue spasms occur in an effort to mobilize the stone through the small duct. This pain may be so severe that it occurs with tachycardia, pallor, diaphoresis, and prostration or extreme exhaustion. Assess the patient for possible shock caused by biliary colic. And that's produced by an obstruction of the cystic duct of the gallbladder. Okay, chart 62.1, key features. Cholecystitis. Episodic or vague upper abdominal pain or discomfort that can radiate to the right shoulder. Pain triggered by a high fat or high volume meal. Anorexia, nausea and vomiting. Dyspepsia, indigestion, eructation, belching, flatulence, gas, feeling or abdominal fullness, rebound tenderness, called Blumberg's sign, fever, jaundice, clay-colored stools, dark urine, steatorrhea, Most common with chronic cholecystitis is jaundice, clay-colored stools, dark urine, and steatorrhea, whatever that is. Considerations for older adults. Older adults and patients with diabetes mellitus may have atypical manifestations, including the absence of pain and fever. Localized tenderness may be the only presenting sign. The older patient may become acutely confused with delirium as the first manifestation of gallbladder disease. Ask patients to describe their daily activity or exercise routines to determine whether they are sedentary. Question whether there is a family history of gallbladder disease. If the patient is female, ask whether she takes hormone replacement therapy, HRT, or birth control pills. Because of gallbladder tenderness, it is difficult to use abdominal palpation and percussion in assessment of the patient with acute cholecystitis. With right subcostal palpation, pain increases with deep inspiration, Murphy's sign. Guarding and rigidity are reliable indicators of peritoneal irritation. Assess for rebound tenderness, Blumberg's sign, and deep palpation is performed by physicians and advanced practice nurses. To elicit rebound tenderness, the healthcare provider pushes his or her fingers deeply and steadily into the patient's abdomen and then quickly releases the pressure. Pain that results from the rebound of the palpated tissue may indicate peritoneal inflammation. Deep palpation below the liver border in the right upper quadrant may reveal a sausage-shaped mass representing the distended, inflamed gallbladder. Percussion over the posterior rib cage worsens localized abdominal pain. In chronic cholecystitis, patients may have slowly developed symptoms and may not seek medical treatment until late symptoms such as jaundice, clay-colored stools, and dark urine occur. Jaundice may also be seen as yellowing of the skin, sclera, and oral mucous membranes. Steatorrhea, or fatty stools, that's what it is, occurs because fat absorption is decreased because of the lack of bile. Bile is needed for the absorption of fats and fat-soluble vitamins in the intestine. As with any inflammatory process, the patient may have an elevated temperature of 99 to 102, or 37 to 39, tachycardia, and dehydration from fever and vomiting. Older adults become dehydrated much quicker than other age groups, and they may not present with a fever. Diagnostic assessment. No laboratory tests are specific for gallbladder disease. A differential diagnosis must rule out with other diseases that may cause similar symptoms, such as peptic ulcer disease and pancreatitis. An increased white blood cell count indicates inflammation. Serum levels of alkaline phosphatase, aspartate aminotransferase, AST, and lactate dehydrogenase, LDH, may be elevated, indicating abnormalities in liver function in patients with biliary obstruction, although this is not very common in patients with cholecystitis without gallstones. The direct or conjugated and indirect or unconjugated serum bilirubin levels are also elevated. If the pancreas is involved, serum amylase and lipase levels are elevated. Calcified gallstones are easily viewed on abdominal X-rays. Stones that are not calcified cannot be seen. Ultrasonography, or US, is the upper right quadrant is the best diagnostic test for cholecystitis. It is safe, accurate, and painless. Acute cholecystitis is seen as edema of the gallbladder wall and pericholecystic fluid. A hepatobiliary scan can be performed to visualize the gallbladder and determine patency of the biliary system. Interventions. Most patients do not respond to non-surgical interventions during the acute phase of cholecystitis. Surgery is the treatment of choice. Non-surgical management. Most people with gallstones have no symptoms. Acute pain occurs when gallstones partially or totally obstruct the cystic or common bile duct. Most patients find that they need to avoid fatty foods to prevent further episodes of biliary colic. Without food and fluids if nausea and vomiting occur, or withhold food and fluids if nausea and vomiting occur. IV therapy is used for hydration. Acute biliary pain requires opioid analgesia such as morphine or hydromorphone dilaudid. In the past, meperidine or Demerol has been the drug of choice because it was thought to cause fewer spasms of the sphincter of Oddi, which blocks bile flow. However, this drug breaks down into a toxic metabolite, or normeperidine, and can cause seizures, especially in older adults. All opioids may cause some degree of sphincter spasm. Anticholinergic drugs such as dicyclamine or Benadryl, Lomine. No, that's not Benadryl. Anticholinergic drugs such as dicyclamine or Bentil or Lomine may be given to relax smooth muscles and decrease ductal tone and spasm. These drugs should not be given to older adults because of adverse drug effects such as constipation, urinary retention, dry mouth, blurred vision, and acute confusion. Ketorolac or Toradol or Acular may be used for them instead. The healthcare provider prescribes antiemetics to control nausea and vomiting. IV antibiotic therapy may also be given. For some patients with small stones, or for those who are not good surgical candidates, several other options are available. For example, a treatment that is commonly used for kidney stones is now approved for gallstones. Extracorporeal shockwave lithotripsy, or ESWL. This procedure can be used only for patients who have a normal weight, cholesterol-based stones, and good gallbladder function. The patient lies on a water-filled pad, and shockwaves break up the large stones into smaller ones that can be passed through the digestive system. During the procedure, he or she may have pain from the movement of the stones or duct or gallbladder spasms. Oral bile salts may be prescribed after the procedure to help dissolve the remaining fragments. Another treatment option in people who cannot have surgery is the insertion of a percutaneous transhepatic biliary catheter to open the blocked duct or ducts so that the bile can flow. Catheters can be placed several ways depending on the condition of the biliary ducts in an internal or external drain. Biliary catheters usually divert bile from the liver into the duodenum to bypass a stricture. When all of the bile enters the duodenum, it is called an internal drain. However, in some cases, a patient has an internal/external drain in which part of the bile empties into a drainage bag. Patients who need this drain for an extended period may have the external drain capped. If jaundice or leakage around the catheter site occurs, teach the patient to reconnect the catheter to a drainage bag and have a follow-up cholangiogram injection done by an interventional radiologist. An external-only catheter is connected either temporarily or permanently to a drainage bag. A reduction in bile drainage indicates that the drain is no longer working. Okay, surgical management. Laparoscopic cholecystectomy. Thank you. Laparoscopic cholecystectomy. Cholecystectomy is a surgical removal of the gallbladder. Two procedures are available to the surgeon for performing this surgery: the laparoscopic cholecystectomy and, far less often, the traditional open approach cholecystectomy. Laparoscopic cholecystectomy. Laparoscopic cholecystectomy, say it one more time. A minimally invasive surgery, MIS, is the gold standard and is performed far more often than the traditional open approach. The advantages of MIS include complications are not common, the death rate is very low, bile duct injuries are rare, patient recovery is quicker, postoperative pain is less severe. The laparoscopic procedure, often called a lapchole, is commonly done on an ambulatory care basis in the same-day surgery suite. The surgeon explains the procedure, the nurse answers questions and reinforces the physician's instructions, reinforce what to expect after surgery, and review pain management, deep breathing exercises, and incentive spirometry use. There is no special preoperative preparation other than the routine preparation for surgery under general anesthesia described in Chapter 16. An IV antibiotic is usually given immediately before or during surgery. During the surgery, the surgeon makes a very small midline puncture at the umbilicus. Additional small incisions may be needed. The abdominal cavity is insufflated with 5 to 4 liters of carbon dioxide. Gasless laparoscopic cholecystectomy using abdominal wall lifting devices is a more recent innovation in some centers. This technique results in improved pulmonary and cardiac function. A trocar catheter is inserted, through which a laparoscope is introduced. The laparoscope is attached to a video camera, and the abdominal organs are viewed on a monitor. The gallbladder is dissected from the liver bed, and the cystic artery and duct are closed. The surgeon aspirates the bile and crushes any large stones, and then extracts the gallbladder through the umbilical port. That sounds fun. Removing the gallbladder with the laparoscopic technique reduces the risk for wound complications. Some patients have pain from carbon dioxide retention in the abdomen. Teach about the importance of early ambulation to promote absorption of the carbon dioxide. Less opioid analgesia is necessary after the laparoscopic procedure than after an open surgical procedure. The patient is usually discharged from the hospital or surgery center within 1 day. Although older and obese patients may stay overnight. Provide postoperative teaching regarding pain management, incision care, and follow-up appointments. After laparoscopic surgery, the patient can return to usual activities much sooner than those having an open cholecystectomy. Most patients are able to resume usual activities within a week. Traditional cholecystectomy. Use of the open surgical approach, abdominal laparotomy, has greatly declined during the past 15 years. The patient undergoing this surgery is usually hospitalized for several days after the procedure. Examples of patients who have this type of surgery include those with chronic lung disease or heart failure who cannot tolerate the carbon dioxide that is used in the laparoscopic procedure. The surgical nurse provides the usual preoperative care and teaching in the operating suite on the day of surgery. The surgeon not only removes the gallbladder through a large incision, but also may explore the biliary ducts for the presence of stones. If the common bile duct is explored, the surgeon may insert a T-tube drain to ensure patency of the duct, although this is not done as commonly today. Trauma to the common bile duct stimulates inflammation, which can slow bile flow and contribute to bile stasis. In addition, the surgeon usually inserts a drainage tube such as the Jackson-Pratt drain. This tube is placed in the gallbladder bed to prevent fluid accumulation. The drainage is usually serosanguinous or serous fluid mixed with blood and is stained with bile in the first 24 hours after surgery. Antibiotic therapy is given to prevent infection. Patient care for a patient having a traditional open cholecystectomy is similar to the care for any patient having abdominal surgery under general anesthesia, as described in Chapter 18. Postoperative incisional pain after a traditional cholecystectomy is controlled with opioids using a patient-controlled analgesia pump, PCA. Encourage the patient to use coughing and deep breathing exercises when pain is controlled. Antiemetics may be necessary for episodes of postoperative nausea and vomiting. Administer the antiemetic early as prescribed to prevent retching associated with vomiting and thus decrease pain related to muscle straining. Provide care for the incision, the surgical drain, and possibly a T-tube. The surgeon typically removes the surgical dressing and drain within 24 hours after surgery. The T-tube, however, may remain in place longer, although it has been associated with many complications. The priority care for the patient with the T-tube is to avoid raising the drainage system above the level of the gallbladder, because it works off of gravity. Chart 62.2 highlights other important nursing care activities associated with the T-tube system. The patient is NPO until fully awake postoperatively. Document the patient's level of consciousness, vital signs, and pain level. Assess the surgical incision for signs of infection, such as excessive redness or purulent drainage. Report changes to the surgeon immediately. Begin ambulation as soon as possible to prevent deep vein thrombosis and promote peristalsis. Chart 62.2 Best practice for patient safety and quality care. Care of the patient with a T-tube. Keep the drainage system below the level of the gallbladder. Maintain the patient in the semi-Fowler's position. Assess the amount, color, consistency, and odor of the drainage initially every 2 to 4 hours and then every 8 hours after the first 24 hours. In the immediate postoperative period, expect bloody drainage, which changes to green-brown bile. Bile output is about 400 milliliters a day with a gradual decrease in amount. Report bile drainage amounts in excess of 1,000 milliliters per day to the physician. Report sudden increases in bile output after a normally decreasing amount or output pattern is established. Assess for foul odor and purulent drainage, which indicates infection or extensive inflammation. Report changes in drainage to the physician. Inspect the skin around the T-tube insertion site for signs of inflammation, including redness, swelling, and erythema, and observe for frank bile leakage. Keep the dressing dry, use the hospital's procedure, and provide drain care and dressing change per protocol. The site is usually cleaned and the dressing changed daily. Never irrigate, aspirate, or clamp a T-tube without a physician's request. Assess the drainage system for pulling, kinking, or tangling of tubing, especially when the patient is positioned toward the right side. When the patient is allowed to eat, clamp the T-tube for 1 to 2 hours per physician's protocol before and after meals. Assess the patient's response to determine tolerance of food. Teach patient to observe stools for return of brown color 7 to 10 days postoperatively. Okay, gradually advance the diet with clear liquids to solid foods as peristalsis returns. Within 1 to 2 days, the patient usually resumes solid foods and is discharged to home. The amount of fat allowed in the patient's diet after a cholecystectomy depends on his or her tolerance of fat. In the early postoperative period, if bile flow is reduced, a low-fat diet may reduce discomfort and prevent nausea. For most patients, a special diet is not required. In collaboration with the nutritionist, advise them to eat nutritious meals and avoid excessive intake of fatty foods, especially fried foods, butter, and fast food. If the patient is obese, recommend a weight reduction program. Teach patients that feces will pass more quickly through the colon after surgery. Some patients have diarrhea, which may need to be controlled with a bile acid binder like cholecystitis. Teach them to keep their incision clean and report any changes that may indicate infection. Remind them to report repeat abdominal or epigastric pain and with vomiting that may occur several weeks to months after surgery. These symptoms indicate possible post-cholecystectomy syndrome, or PCES. PCES occurs in fewer than 10% of patients with gallbladder surgery. However, patients who have it are usually discouraged that they have pain after already having surgery to cure it. Causes of PCES are listed in Table 62.2. Management depends on the exact cause, but usually involves the use of the endoscopic retrograde cholangiopancreatography, ERCP, to find the cause of the problem and repair it. This procedure-related nursing care are described in Chapter 55. Collaborative care includes pain management, antibiotics, nutrition and hydration therapy, possibly short-term parenteral nutrition, and control of nausea and vomiting. Table 62.2, causes of post-cholecystectomy syndrome. Pseudocyst, common bile duct or CBD leak, CBD or pancreatic duct stricture, sphincter of Oddi dysfunction, retained or new CBD gallstone, pancreatic or liver mass, primary sclerosing cholangitis, and diverticular compression. NCLEX examination challenge. An older client is admitted to the post-anesthesia recovery unit, PACU, after having a laparoscopic cholecystectomy. Which action is the nurse's priority in caring for the patient? Assess T-tube drainage and the catheter site for signs of infection. Teach the client to avoid fatty foods for the first 6 weeks after surgery. Manage the pain that is caused by carbon dioxide gas. Or remind the client to deep breathe and cough every 2 hours. Probably C, be immediately after surgery. Okay, and that's cholecystitis. Okay, 1344 to 1360. Cirrhosis and hepatitis. The liver is the largest and one of the most vital internal organs, performing more than 400 functions and affecting every system in the body. Cirrhosis is extensive, irreversible scarring of the liver, usually caused by a chronic reaction to hepatic inflammation and necrosis. The disease typically develops slowly and has a progressive, prolonged, destructive course, resulting in end-stage liver disease. The most common causes of cirrhosis in the United States are alcoholic liver disease and hepatitis C. Worldwide, hepatitis B and hepatitis D are the leading causes. Without liver transplantation, cirrhosis is usually fatal. Pathophysiology. Cirrhosis is characterized by widespread fibrotic or scarred bands of connective tissue that change the liver's normal makeup. Inflammation caused by either toxins or disease result in extensive degeneration and destruction of hepatocytes or liver cells. As cirrhosis develops, the tissue becomes nodular. These nodules can block bile ducts and normal blood flow throughout the liver. Impairments in blood and lymph flow result from compression caused by excessive fibrous tissue. In early disease, the liver is usually enlarged, firm, and hard. As the pathologic process continues, the liver shrinks in size, resulting in decreased liver function, which can occur in weeks to years. 40% of cirrhotic patients are asymptomatic. This impaired liver function results in elevated serum liver enzymes. Cirrhosis of the liver can be divided into several types depending on the cause of the disease. Laennec's or alcoholic cirrhosis caused by chronic alcoholism, post-necrotic cirrhosis caused by viral hepatitis and certain drugs or chemicals, biliary cirrhosis, also called cholestatic, caused by chronic biliary obstruction, usually from gallbladder disease, and cardiac cirrhosis caused by heart failure as a rare complication. Complications of cirrhosis. Common problems and complications associated with hepatic cirrhosis depend on the amount of drainage sustained by the liver. In compensated cirrhosis, the liver is scarred but can still perform essential functions without causing major symptoms. In decompensated cirrhosis, liver function is impaired with the obvious manifestations of liver failure. The loss of hepatic function contributes to the development of metabolic abnormalities. Hepatic cell damage may lead to these common complications: portal hypertension, ascites, bleeding, esophageal varices, coagulation defects, jaundice, portal systemic encephalopathy or PSE with hepatic coma, and hepatorenal syndrome, and spontaneous bacterial peritonitis. Portal hypertension is a persistent increase in pressure within the portal vein. Is a major complication of cirrhosis. It results from increased resistance to or obstruction or blockage of the flow of blood through the portal vein and its branches. The blood meets resistance to flow and seeks collateral or alternative venous channels around the high pressure area. Blood flow backs into the spleen, causing splenomegaly or spleen enlargement. Veins in the esophagus, stomach, intestines, abdomen, and rectum become dilated. Portal hypertension can result in ascites, abdominal fluid, esophageal varices or distended veins, prominent abdominal veins or caput medusa, and hemorrhoids. Ascites is the collection of free fluid within the peritoneal cavity caused by increased hydrostatic pressure from portal hypertension. The collection of plasma protein in the peritoneal fluid reduces the amount of circulating plasma protein in the blood. When this decrease is combined with the inability of the liver to produce albumin because of impaired liver cell function, the serum colloid osmotic pressure is decreased in the circulatory system. The result is a fluid shift from the vascular system into the abdomen, a form of third spacing. Massive ascites may cause renal vasoconstriction, triggering the renin-angiotensin system. This results in sodium and water retention, which increases hydrostatic pressure and the vascular volume, which leads to more ascites. As a result of portal hypertension, the blood backs up from the liver and enters the esophageal and gastric veins. Esophageal varices occurs when fragile, thin-walled esophageal veins become distended from increased pressure. The potential for varices to bleed depends on their size. Size is determined by direct endoscopic observation. Varices occur more or most often in the distal esophagus, but can also be present in the stomach and rectum. Bleeding esophageal varices is a life-threatening medical emergency. There can be severe blood loss, resulting in shock from hypovolemia. The bleeding may be either hematoemesis or vomiting blood, or melena, black tarry stools. Loss of consciousness may occur before any observed bleeding. Variceal bleeding can occur spontaneously with no precipitating factors. However, any activity that increases abdominal pressure may increase the likelihood of a variceal bleed, including heavy lifting or vigorous physical exercise. In addition, chest trauma or dry, hard food in the esophagus can cause bleeding. Patients with portal hypertension may also have portal hypertensive gastropathy. This complication can occur with or without esophageal varices. Slow gastric mucosal bleeding occurs, which may result in chronic slow blood loss, occult positive stools, and anemia. In patients with cirrhosis, the production of bile in the liver is decreased. This prevents the absorption of fat-soluble vitamins, e.g. vitamin K. Without vitamin K, clotting factors 2, 7, 9, and 10 are not produced in sufficient quantities, and the patient is susceptible to bleeding and easy bruising. These abnormalities are confirmed by coagulation studies. Splenomegaly, enlarged spleen, results from the backup of blood into the spleen. The enlarged spleen destroys platelets, causing thrombocytopenia, low serum platelet count, and increased risk for bleeding. Thrombocytopenia is often the first clinical sign that a patient has liver dysfunction. Jaundice, yellow coloration of the skin. In patients with cirrhosis, it is caused by one of two mechanisms: hepatocellular disease or intrahepatic obstruction, table 61.1. Hepatocellular jaundice develops because the liver cells cannot effectively excrete bilirubin. This decreased excretion results in excessive circulating bilirubin levels. Intrahepatic obstructive jaundice results from edema, fibrosis, or scarring of the hepatic bile channels and bile ducts, which interferes with normal bile and bilirubin excretion. Portal systemic encephalopathy, or PSE, is also known as hepatic encephalopathy and hepatic coma in the later stages. It is a disorder seen in liver failure and cirrhosis that affects the function of the brain. Patients report sleep disturbances, mood disturbances, mental status changes, and speech problems early as this complication begins. Later neurologic symptoms include an altered level of consciousness, impaired thinking processes, and neuromuscular problems. Encephalopathy may be acute and reversible with early intervention. The exact mechanisms causing hepatic encephalopathy are not clearly understood, but probably are the result of the shunting of portal venous blood into the central circulation so that the liver is bypassed. As a result, toxic substances absorbed by the intestine are not broken down or detoxified and may lead to metabolic abnormalities such as elevated serum ammonia and gamma-aminobutyric acid, or GABA. Elevated ammonia levels are usually common in patients with hepatic encephalopathy. However, they are not a clear indicator of the presence of encephalopathy. Some patients may have major impairment with high elevations of serum ammonia, and elevations of ammonia can occur without evidence of encephalopathy. Table 61.1, laboratory diagnostic differentiation of jaundice. Test. Serum bilirubin, indirect, uncoagulated, would be hepatocellular jaundice is increased, obstructive jaundice slightly increased, and hemolytic jaundice increased. Direct or conjugated, unconjugated before, and direct would be conjugated, that'd be hepatocellular jaundice is increased, obstructive jaundice moderately increased, hemolytic jaundice normal. Urine bilirubin would be hepatocellular jaundice would be increased, obstructive jaundice increased, and hemolytic jaundice none. Stool. The test for stool would be hepatocellular jaundice would be normal to decreased, obstructive jaundice none, and hemolytic jaundice would be increased. A urine test would show hepatocellular jaundice normal to increased, obstructive jaundice none, and hemolytic jaundice increased. Table 61.2, stages of portal systemic encephalopathy. Stage 1, prodromal, be subtle manifestations that may not be recognized immediately: personality changes, behavior changes, agitation, belligerence, emotional ability, euphoria, depression, impaired thinking, inability to concentrate, fatigue, drowsiness, slurred or slowed speech, sleep pattern disturbances. Stage 2, impending, would be continuing mental changes, mental confusion, disorientation to time, place, or person, asterixia, or hand flapping. Stage 3, stuporous, would be progressive deterioration, marked mental confusion, stuporous, drowsy but arousable, abnormal electrocephalogram tracing, muscle twitching, hyperreflexia, and an astrixia or astrixis. Stage 4, comatose, unresponsiveness leading to death in most patients progressing to this stage, unarousable, obtunded, response to painful stimuli, no astrixis, positive Babinski's sign, muscle rigidity, fetor hepaticus, would be a characteristic liver breath, musty, sweet odor, and seizures. So PSC may develop slowly in patients with chronic liver disease and go undetected until the late stages. Symptoms develop rapidly in acute liver dysfunction. 4 stages of development have been identified: prodromal, impending, stuporous, and comatose. The patient's symptoms may gradually progress to coma or fluctuate among the 4 stages. Factors that may lead to PSC include high protein diet, infections, hypovolemia, deficient fluid volume, hypokalemia, deficient serum potassium, constipation, GI bleeding causes a large protein load in the intestines, drugs, e.g. hypnotics, opioids, sedatives, analgesics, diuretics. PSC may also occur after paracentesis or shunting procedures. The prognosis depends on the severity of the underlying cause, the precipitating factors, and the degree of the liver dysfunction. The development of hepatorenal syndrome, or HRS, indicates a poor prognosis for the patient with liver failure. It is often the cause of death in these patients. This syndrome is manifested by a sudden decrease in urinary flow, less than 500 milligrams in a 24-hour period, or oliguria, elevated blood urea, nitrogen, and creatinine levels with abnormally decreased urine sodium excretion, increased urine osmolarity. HRS often occurs after clinical deterioration from GI bleeding or the onset of PSC. It may also complicate other liver diseases, including acute hepatitis and fulminant liver failure. Patients with cirrhosis and ascites may develop acute spontaneous bacterial peritonitis, SBP. Those who are particularly susceptible are patients with very advanced liver disease. This may be the result of low concentration of proteins. Proteins normally provide some protection against bacteria. The bacteria responsible for SBP are typically from the bowel and reach the acetic, but not acidic, but acetic fluid after migrating through the bowel wall and transversing the lymphatics. Clinical manifestations vary but may include fever, chills, and abdominal pain and tenderness. However, manifestations can also be minimal, with only mild symptoms in the absence of fever. Worsening encephalopathy and increased jaundice may also present without abdominal symptoms. The diagnosis of SBP is made when a sample of acetic fluid is obtained by paracentesis for cell counts and culture. An acetic fluid leukocyte count of more than 250 polymorphonuclear, or PMN, leukocytes can be the basis for treatment. And that's spontaneous bacterial peritonitis, SBP. Etiology. Cirrhosis can occur as a result of many factors and diseases. Alcohol has a direct toxic effect on the hepatocytes and causes liver inflammation, alcoholic hepatitis. The liver becomes enlarged with cellular degeneration and infiltration by fat leukocytes and lymphocytes. Over time, the inflammatory process decreases and the destructive phase increases. Early scar formation is caused by fibroblasts, infiltration, and collagen formation. Damage to the liver tissue progresses as malnutrition and repeated exposure to the alcohol continue. If alcohol is withheld, the fatty infiltration and inflammation is reversible. If alcohol abuse continues, widespread scar tissue formation and fibrosis infiltrate the liver as a result of cellular necrosis. The amount of alcohol necessary to cause cirrhosis varies widely from person to person, and there are gender differences. In women, it may take as few as 2 or 3 drinks per day over a minimum of 10 years. In men, perhaps 6 drinks per day over the same time period may be needed to cause disease. Binge drinking can increase risk for hepatitis and fatty liver. Hepatitis C is now the leading cause of cirrhosis in the United States. It is an infectious, blood-borne illness that usually causes chronic disease. Inflammation caused by infection over time leads to progressive scarring of the liver. It usually takes decades for cirrhosis to develop, although alcohol use in combination with hepatitis C may speed the process. Hepatitis B and D are the most common causes of cirrhosis worldwide. Hepatitis B also causes inflammation and low-grade damage over decades that can ultimately lead to cirrhosis. Hepatitis D is another virus that infects the liver, but only in people who already have hepatitis B. See discussion of hepatitis on page 1356. Table 61.3 lists additional causes of liver cirrhosis. Incidence/prevalence. The incidence of cirrhosis in the United States is not well known, but about 27,000 die each year. Annual hospital stays are over 400,000. The disease affects twice as many men as women. Patient-centered collaborative care assessment. History. Obtain data from patients with suspected cirrhosis, including age, gender, and employment history, especially history of exposure to chemical toxins or drugs. Keep in mind that all exposures are important regardless of how long ago they occurred. Determine whether there has ever been a needle stick injury. Sexual history and preference may be important in determining an infectious cause of liver disease. Inquiry about whether there is a family history of alcoholism and or liver disease. Ask the patient to describe his or her alcohol intake, including the amount consumed during a given period. Is there a history of drug use, including oral, IV, and intranasal forms? Is there a history of tattoos? Has the patient been in the military or in prison? Is the patient a healthcare worker, firefighter, or police officer? For patients previously or currently in an alcohol or drug recovery program, how long have they been sober? This information is sensitive and often difficult for the patient to answer. Be sure to establish why you are asking these questions and accept answers in a non-judgmental manner. Provide privacy during the interview. For many people, the behaviors causing the liver disease occurred years before the onset of their current illness, and they are regretful and often embarrassed. Table 61.3. Common causes of cirrhosis: alcoholic liver disease, viral hepatitis, autoimmune hepatitis, steatohepatitis from fatty liver, drugs and chemical toxins, gallbladder disease, metabolic genetic causes, and cardiovascular disease. Ask the patient about the previous medical conditions, such as an episode of jaundice or acute viral hepatitis, biliary tract disorders, viral infections, surgery, blood transfusions, autoimmune disorders, obesity, altered lipid profile, heart failure, respiratory disorders, or liver injury. Physical assessment/clinical manifestations. Because cirrhosis has a slow onset, many of the early manifestations are vague and non-specific. Assess for fatigue, significant change in weight, GI symptoms, abnormal pain, and liver tenderness, both of which may be ignored by the patient. Pruritus or itching. Liver function problems are often found during a routine physical examination or when laboratory tests are completed for an unrelated illness or problem. The patient with compensated cirrhosis may be completely unaware that there is a liver problem. The first sign may present before the onset of symptoms when routine laboratory tests, pre-surgical evaluations, or life and health insurance assessments show abnormalities. These tests should indicate or could indicate abnormal liver function or thrombocytopenia, requiring a more thorough diagnostic workup. The development of late signs of advanced cirrhosis may cause the patient to seek medical treatment. GI bleeding, jaundice, ascites, and spontaneous bruising indicate poor liver function and complications of cirrhosis. Thoroughly assess the patient with liver dysfunction or failure because it affects every body system. Figure 61.1. The clinical picture and course vary from patient to patient depending on the severity of the disease. Assess for obvious yellowing of the skin, jaundice, and sclera. I don't know. Dry skin, red rashes, purpuric lesions such as petechiae, round pinpoint, red-purple lesions, or ecchymosis, large purple, blue, or yellow bruises. Warm and bright red palms of the hands, palmar erythema, vascular lesions with a red center and radiating branches known as spider angiomas, telangiectasis, and spider nevi or vascular spiders on the nose, cheeks, upper thorax, and shoulders. Peripheral dependent edema of the extremities and sacrum, clubbing of nails, fixed flexion of fingers. Abdominal assessment. Usually massive ascites can be detected as a distended abdomen with bulging flanks. The umbilicus may protrude, and dilated abdominal veins or caput medusae may radiate from the umbilicus. Ascites can cause physical problems, for example, orthopenia and dyspnea. Orthopnea and dyspnea from increased abdominal distension can interfere with lung expansion. The patient may have difficulty maintaining an erect body posture. The problems with balance may affect walking. Inspect and palpate for the presence of inguinal or umbilical hernias, which are likely to develop because of increased intra-abdominal pressure. Minimal ascites is often more difficult to detect, especially in the obese patient. Advanced assessment techniques such as the percussion test for shifting dullness and the presence of a fluid wave may be performed by the healthcare provider. When performing an assessment of the abdomen, keep in mind that hepatomegaly, liver enlargement, occurs in many cases of early cirrhosis. Splenomegaly is common in non-alcoholic causes of cirrhosis. As the liver deteriorates, it may become hard and small. The advanced practice nurse or other healthcare provider palpates the right upper quadrant for hepatomegaly below the costal ribcage border. It may also be assessed by percussing for dullness over the enlarged liver. Measure the patient's abdominal girth to evaluate the progression of ascites. Figure 61.2. To measure abdominal girth, the patient lies flat while the nurse or other examiner pulls a tape measure around the large diameter, usually over the umbilicus of the abdomen. The girth is measured at the end of exhalation. Mark the abdominal skin and flanks to ensure the same tape measure placement on subsequent readings. Taking daily weights, however, is the most reliable indicator of fluid retention. Other physical assessment. Observe vomitus and stool for blood. This may be indicated by frank blood in the excrement or by a positive fecal occult blood test or FOBT, Hemacheck and Hematest. Gastritis, stomach ulceration, or oozing esophageal varices may be responsible for the blood in the stool. Note the presence of fetor hepaticus, which is the distinctive breath odor of chronic liver disease and portal systemic encephalopathy, or PSC, and is characterized by a fruity or musty odor. Fetor hepaticus results from the inability of the damaged liver to metabolize and detoxify mercaptan, which is produced by bacterial breakdown of methionine, a sulfurous amino acid. Amenorrhea, no menstrual period, may occur in women, and men may exhibit testicular atrophy or gynecomastia, enlarged breasts, and deteriorating testicles and enlarged breasts for men, and impotence as a result of inactive hormones. Patients with problems of the hematologic system caused by hepatic failure may have bruising and petechiae, small purplish hemorrhagic spots on the skin. Continually assess the patient's neurologic function. Subtle changes in mental status and personality often progress to coma, a late complication of PSC. Monitor for astrixis, a coarse tremor characterized by rapid, non-rhythmic extensions and flexions in the wrists and fingers. It's non-rhythmic extensions and flexions of the wrists and fingers. Okay. Psychosocial assessment. The patient with hepatic cirrhosis may undergo subtle or obvious personality, cognitive, and behavioral changes, such as agitation. He or she may experience sleep pattern disturbances or may exhibit signs of emotional lability, fluctuations in emotions, euphoria, elevated mood, or depression. A psychosocial assessment identifies needs and helps guide care. Repeated hospitalizations are common for patients with cirrhosis. It is a life-altering chronic disease, impacting not only the patient but also the immediate and extended family members. There are significant emotional, physical, and financial changes. Substance abuse may continue even as health worsens. It is important whenever possible to use resources available to these patients and their families. Collaborate with social workers, substance abuse counselors, and mental health/behavioral care healthcare professionals as needed for patient assessment and management. Laboratory assessment. Laboratory study abnormalities are common in patients with liver disease. Serum levels of aspartate aminotransferase, AST, alanine aminotransferase, ALT, and lactate dehydrogenase, LDH, may be elevated because these enzymes are released into the blood during hepatic inflammation. However, as the liver deteriorates, the hepatocytes may be unable to create an inflammatory response, and the AST and ALT may be normal. ALT levels are more specific to the liver because AST can be found in muscle, kidney, brain, and heart. An AST/ALT ratio greater than 2 is usually found in alcoholic liver disease. Table 61.4. Assessment of abnormal laboratory findings in liver disease. Serum and abnormal findings. Serum enzymes. Elevated serum aspartate aminotransferase, AST. Significance would be hepatic cell destruction. Hepatitis, most specific indicator. Then an elevated serum alanine aminotransferase, ALT. That would be hepatic cell destruction and hepatitis. Then abnormal finding elevated lactate dehydrogenase, or LDH, would be hepatic cell destruction, and an elevated serum alkaline phosphatase would be obstructive jaundice or hepatic metastasis. Bilirubin, abnormal findings for bilirubin would be elevated serum total bilirubin, would be hepatic cell disease. Elevated serum direct conjugated bilirubin would be hepatitis, liver metastasis. Elevated serum indirect unconjugated bilirubin would be cirrhosis. Elevated urine bilirubin would be hepatocellular obstruction, viral or toxic liver disease. Elevated urine urobilinogen would be hepatic dysfunction. Decreased fecal urobilinogen would be obstructive liver disease. Suss that out. Let's see. Serum proteins. Increased serum total protein, acute liver, would be acute liver disease. Decreased serum total protein would be chronic liver disease. Decreased serum albumin would be severe liver disease. And elevated serum globulin would be immune response to liver disease. Other tests would be elevated serum ammonia, would be advanced liver disease or portal systematic encephalopathy or PSE, prolonged prothrombin time PT or international normalized ratio would mean hepatic cell damage and decreased synthesis of prothrombin. Alkaline phosphatase and gamma glutamyl transpeptidase or GGT levels are caused by biliary obstruction and therefore may increase in patient with cirrhosis. However, alkaline phosphatase also increases when bone disease is present. Total serum bilirubin levels also rise. Indirect bilirubin levels increase in patients with cirrhosis because of the inability of the failing liver to excrete bilirubin. Therefore, bilirubin is present in the urine or urobilinogen is in increased amounts. Fecal urobilinogen and concentrations is decreased in patients with biliary tract obstruction. These patients have light or clay-colored stools. Total serum protein and albumin levels are decreased in patients with severe or chronic liver disease as a result of decreased synthesis by the liver. Prothrombin time international normalized ratio, PT and INR, is prolonged because the liver decreases the production of prothrombin. The platelet count is low, resulting in a characteristic thrombocytopenia of cirrhosis. Anemia may be reflected by decreased red blood cell count, hemoglobin, and hematocrit values. The white blood cell count may also be decreased. Ammonia levels are usually elevated in patients with advanced liver disease. Serum creatinine may be elevated in patients with deteriorating kidney function. Dilutional hyponatremia or low serum sodium is common in patients with ascites. Imaging assessment. Plain X-rays of the abdomen may show hepatomegaly, splenomegaly, or massive ascites. A computed CT scan may be requested. MRIs and other tests used to diagnose the patient with liver disease. It can reveal mass lesions, giving additional specific information. This information is helpful in determining whether the condition is malignant or benign. Other diagnostic assessment. Ultrasound of the liver is the most, or is often the first assessment for ultrasound is often the first assessment of a person with suspected liver disease to detect ascites, hepatomegaly, and splenomegaly. It can also determine the presence of biliary stones or biliary duct obstruction. Liver US or ultrasound is useful in detecting portal vein thrombosis and evaluating whether the direction of portal blood flow is normal. Some patients being assessed for liver disease require biopsies to determine the exact pathology and the extent of disease progression. This procedure can be problematic because a large number of patients are at risk for bleeding. Even a percutaneous, through the skin, biopsy can pose a significant risk to patients. To minimize this risk, an interventional radiologist can perform a liver biopsy using a long sheath through a jugular vein that then is threaded into the hepatic vein and liver. A tissue sample is obtained for microscopic evaluation. If a biopsy procedure is not possible, a radioisotope liver scan may be used to identify cirrhosis or other diffuse disease. The physician may request arteriography if ultrasound is not conclusive in finding portal vein thrombosis. To evaluate the portal vein and its branches, a portal venogram may be performed instead by passing a catheter into the liver and into the portal vein. This procedure is described on page 1354 in the transjugular intrahepatic portal systemic shunt section. The physician may perform an esophagogastroduodenoscopy, an EGD, to directly visualize the upper GI tract and to detect the presence of bleeding or oozing, esophageal varices, stomach irritation, and ulceration, or duodenal ulceration and bleeding. EGD is performed by introducing a flexible fiber optic endoscope into the mouth, esophagus, and stomach while the patient is under moderate sedation. A camera attached to the scope permits direct visualization of the mucosal lining of the upper GI tract. An endoscopic retrograde cholangiopancreatography, or ERCP, uses the endoscope to inject contrast material via the sphincter of Oddi to view the biliary tract and allow for stone removals, sphincterotomies, biopsies, and stent placements if required. These procedures are described in more detail in Chapter 55. Analysis: common nursing diagnoses and collaborative problems. The most common nursing diagnosis for patients with cirrhosis is excessive fluid volume related to edema or portal hypertension. The primary collaborative problems for patients with cirrhosis are potential for hemorrhage and potential for portal systemic encephalopathy, or PSE. Additional nursing diagnoses and collaborative problems: in addition to the common nursing diagnoses, patients with cirrhosis may have one or more of these: risk for imbalanced nutrition, less than body requirements related to inability to ingest or digest foods due to biologic factors, ineffective breathing pattern related to decreased diaphragmatic excursion and pressure on the diaphragm from acides, chronic pain related to abdominal pressure, risk for infection related to GI bleeding, risk for impaired skin integrity related to pruritus and altered nutritional state, ineffective coping related to a chronic and potentially fatal disease, sexual dysfunction related to altered hormonal function and decreased libido, disturbed body image related to biophysical changes, distended abdomen, and skin lesions. Additional collaborative problems include potential for drug toxicity, potential for hepatorenal syndrome, potential for hepatopulmonary syndrome, potential for spontaneous bacterial peritonitis, potential for hyponatremia, and potential for hypokalemia. Planning and implementation: excessive fluid volume. Planning expected outcomes. The patient with cirrhosis is expected to have water balance in the intracellular and extracellular compartments of the body. Indicators include that the patient will have normal blood pressure, normal peripheral pulses, normal mean arterial pressure, 24-hour intake and output balance, stable body weight, normal serum electrolytes, and normal hematocrit. Interventions: fluid accumulations are minimal during the early stages of acides, and therefore interventions are aimed at preventing the accumulation of additional fluid and moving the existing fluid collection. Non-surgical treatment measures are used to treat acides. See the concept map for liver failure on page 1351. Non-surgical management. Supportive measures to control abdominal acides include nutrition therapy, drug therapy, paracentesis, and comfort measures. The patient's fluid and electrolyte status is also carefully monitored. If the patient is jaundiced, he or she will likely scratch the skin before the excess bilirubin products, or because the excess bilirubin products cause irritation and pruritus or itching. Teach the patient to use cool rather than warm water on the skin and to not use an excessive amount of soap. Teach unlicensed assisted personnel to use lotion to soothe the skin. Assess for open skin areas from scratching. Nutrition therapy. The healthcare provider usually places the patient with abdominal acides on a low-sodium diet as an initial means of controlling fluid accumulation in the abdominal cavity. The amount of daily sodium intake restriction varies, but a 1 to 2 gram or 2,000 milligram sodium restriction may be tried first. In collaboration with the nutritionist, explain the purpose of the restriction and advise the patient and family to read the sodium content labels on all food and beverages. Table salt should be completely excluded. Low sodium diets may be distasteful, so suggest alternative flavoring additives such as lemon, vinegar, parsley, oregano, and pepper. Remind the patient that seasoned and salty foods is an acquired taste. In time, he or she will become used to the decrease in dietary sodium. In general, patients with late-stage cirrhosis are malnourished and have multiple dietary deficiencies. Vitamin supplements such as thiamine, folate, and multivitamin preparations are typically added to the IV fluids because the liver cannot store vitamins. Oral vitamins are prescribed when IV fluids administration is discontinued. Drug therapy. Okay. The healthcare provider usually prescribes a diuretic to reduce fluid accumulation and to prevent cardiac and respiratory problems. Monitor the effect of diuretic therapy by assessing intake and output, weighing the patient daily, measuring abdominal girth, documenting peripheral edema, and assessing electrolyte levels. Serious electrolyte imbalances such as hypokalemia, decreased potassium, and hyponatremia, decreased sodium, may occur with diuretic therapy. Depending on the diuretic selected, the provider may prescribe an oral or IV potassium supplement. Some clinicians prescribe a combination of furosemide or Lasix and spirolactone or aldactone as a combination diuretic therapy for the treatment of ascites. Because these drugs work differently, they are used for maintenance of sodium and potassium balance. Furosemide causes potassium loss, whereas spirolactone conserves it in the body. Keep in mind that all patients with ascites have the potential to develop spontaneous bacterial peritonitis, or SBP, from bacteria in the collected ascitic fluid. In some patients, mild symptoms such as a low-grade fever and loss of appetite occur. In others, there may be abdominal pain, fever, and change in mental status. When performing an abdominal assessment, listen for bowel sounds and assess for abdominal wall rigidity. A sample of ascitic fluid is usually sent for culture before drug therapy begins. Quinolones such as norfloxacin or Norizin are the drugs of choice for SBP. If the patient is allergic to this class of antibiotics, combination antibiotics like trimethoprim, sulfamethoxazole, or Bactrim are given. Paracentesis. Although not as commonly today, abdominal paracentesis may be needed. Nursing implications associated with this procedure are described in Chart 61.1. This procedure is performed at the bedside or in an ambulatory care setting. The physician inserts a trocar catheter into the abdomen to remove and drain ascitic fluid from the peritoneal cavity. This procedure is done using ultrasound for added safety. In some situations, a short-term ascites drain catheter may be placed while the patient is awaiting surgical intervention. Once a primary treatment modality for ascites, paracentesis is more commonly used as a diagnostic tool to examine ascitic fluid. If SBP is suspected, a sample of fluid is withdrawn and sent for cell count and culture. If the patient has symptoms of infection, the physician may prescribe antibiotics while awaiting the culture results. Chart 61.1. Best practice for patient safety and quality care. The patient with paracentesis. Explain the procedure and ask patient questions. Obtain vital signs, including weight. Ask the patient to void before the procedure to prevent injury to the bladder. That's exclamation point. Position the patient in bed with the head of the bed elevated. Monitor vital signs per protocol or physician's request. Measure the drainage and record accurately. Describe the collected fluid. Label and send the fluid for laboratory analysis. Document in the patient record that specimens were sent. After the physician removes the catheter, apply dressing to the site. Assess for leakage. Maintain bed rest per protocol. Weigh the patient after the paracentesis. Document the patient record. Weight the patient. Document in the patient record weight both before and after paracentesis. Back to text. High-volume paracentesis may be used for temporary relief of abdominal pressure because acidase that does not respond to diuretic and diet may cause severe respiratory and abdominal distress. To relieve acute symptoms, the physician slowly drains as much as 4 liters of acidic fluid. Hypovolemia may occur with rapid or excessive fluid removal because the patients have adjusted to the excessive fluid volume in the abdomen. Rapid, drastic removal of acidic fluid leads to decreased abdominal pressure, which may contribute to vasodilation and shock. Observe for impending signs of shock, e.g. hypotension and tachycardia, from fluids shifts during and immediately after the procedure. Albumin or other volume replacer infusion is given after high-volume paracentesis to avoid depleting the intravascular space and to avoid hypotension. Serial or repeated paracentesis procedures may be needed for continued acidase. Patients are at high risk for increased incidence of protein depletion, hypovolemia, and electrolyte imbalances. Monitor for these complications. Several drugs such as cetabaptan and midodrine or Orvitan are being investigated as treatments for acidase to decrease the use of paracentesis. Comfort measures. Excessive acidic fluid volume may cause the patient to have respiratory problems. He or she may develop hepatopulmonary syndrome. Dyspnea develops as a result of increased intra-abdominal pressure, which limits thoracic expansion and diaphragmatic excursion. Monitor the patient's oxygen saturation with pulse oximetry. If needed, apply oxygen therapy to ease breathing. Elevate the head of the bed to at least 30 degrees or as high as the patient wants to improve breathing. Encourage the patient to sit in a chair, this upright position with his or her feet elevated to decrease dependent ankle edema, often relieves dyspnea. Weigh the patient daily or delegate and supervise this activity. Fluid electrolyte management. Fluid and electrolyte imbalances are common as a result of the disease or treatment. Laboratory tests such as blood, urea, nitrogen, BUN, serum protein, hematocrit, and electrolytes help determine fluid and electrolyte status. Other nursing interventions activities are listed in Chart 61.2. Chart 61.2, Interventions Activities, the patient with cirrhosis, fluid electrolyte management, regulation and prevention of complications from altered fluid and or electrolyte levels. Obtain laboratory specimens for monitoring of altered fluid and electrolyte levels, e.g. hematocrit, BUN, protein, sodium, and potassium levels as appropriate. Keep an accurate record of intake, output. Weigh patient daily and monitor trends. Monitor for signs and symptoms of fluid retention. Monitor vital signs as appropriate. Administer prescribed supplemental electrolytes or as appropriate. Bleeding precautions. Reduction of stimuli that may induce bleeding or hemorrhage in at-risk patients. Monitor the patient closely for hemorrhage. Monitor for signs and symptoms of persistent bleeding, e.g. check all secretions for frank or occult blood. Monitor coagulation studies including prothrombin time, PT, partial thromboplastin time, PTT, fibrinogen, fibrin degradation / split products, and platelet counts as appropriate. Monitor orthostatic vital signs, including blood pressure. Use electric razor instead of straight edge for shaving. Use soft toothbrush or toothlets for oral care. Avoid injection, IV, IM, or subcutaneous as appropriate. Protect the patient from trauma, which may cause bleeding. Neurologic monitoring, collection and analysis of patient data to prevent or minimize neurologic complications. Monitor level of consciousness, monitor level of orientation, monitor recent memory, attention span, past memory, mood, affect, and behaviors. Monitors vital signs, temperature, blood pressure, pulse, and respirations, BUN, blood urea, nitrogen. Okay, surgical management. When medical management fails to control acidase, the physician may choose surgical intervention to divert acidase into the venous system by creating a shunt. Older shunts, such as portic caval and peritoneovenous shunts, to divert fluid away from the diseased liver into the venous system are rarely done today because the serious potential for complications. Patients with ascites are poor surgical risks. The transjugular intrahepatic portal system shunt, or TIPS, is a non-surgical procedure that is used to control long-term ascites and to reduce variceal bleeding. This procedure is described in the discussion of interventions at right in the potential for hemorrhage section. The patient with cirrhosis has many medical problems. An optimal physical state is desired before surgery is performed. Electrolyte imbalances are corrected, and abnormal coagulation is treated with the administration of fresh frozen plasma and vitamin K. Packed red blood cells are made available for transfusion because these patients have bleeding tendencies. Provide the usual preoperative and postoperative care for a patient undergoing abdominal surgery. Remain aware that the ascitic fluid is routed into the venous system, resulting in vascular volume expansion and hemodilution. Monitor vital signs carefully and frequently as per surgeon protocol. An increase in blood pressure reflects an increase in vascular volume. Auscultate breath sounds for the presence of crackles, which indicates excessive lung fluid. A diuretic such as furosemide or Lasix is usually prescribed to rid the body of excessive fluid. Note any abnormal results of coagulation studies, prothrombin, INR, and partial PTT. Delegate and supervise nursing activities such as weighing the patient, weighing abdominal girth, and recording urine output each shift to determine the effectiveness of the shunting procedure. Potential for hemorrhage. Planning expected outcomes. The patient is expected to be free of bleeding episodes. However, if the patient has a hemorrhage, it is expected to be controlled by prompt, evidence-based interdisciplinary interventions. All patients with cirrhosis should be screened for esophageal varices by endoscopy to detect them early before they bleed. If patients have varices, they are placed on preventative therapy. If acute bleeding occurs, early interventions are used to manage it. Because massive esophageal bleeding can cause rapid blood loss, emergency interventions are needed. The role of drug therapy is to prevent bleeding in patients who have varices. A non-selective beta-blocking agent such as propranolol or Indirel or nadolol or Corgard with or without a nitrate is usually prescribed. The patient starts on a low dose that is increased every 3 to 5 days until the heart rate is about 55 beats per minute. By decreasing heart rate and the hepatic venous pressure gradient, the chance of bleeding may be reduced. If bleeding occurs, the healthcare team intervenes quickly to control it by providing interventions such as infused vasoactive therapy or endoscopic procedure. After the acute bleeding episode has been controlled, the patient may require a transjugular intrahepatic portal systemic shunt, or TIPS, to decrease portal hypertension, thereby decreasing the risk of further variceal bleeding. The patient is managed in the critical care unit. Short-term esophagogastric balloon tamponade using a Minnesota or Sengstaken Blackmore tube is not commonly used today because it is difficult to use, uncomfortable for the patient, and prone to dangerous complications. However, it may be needed if the patient is not able to have an endoscopy or TIPS procedure. Similar to a nasogastric tube, the tube is placed through the nose and into the stomach. An attached balloon is inflated to apply pressure to the bleeding variceal area. Before this tamponade, the patient is usually intubated and placed on a mechanical ventilator to protect the airway. Some patients may need liver transplantation to prevent further bleeding episodes. Vasoactive therapy. IV octreotide or sandostatin, a somatostatin analog, is the most common drug used in the United States for acute hemorrhage due to esophageal varices. Terlipressin or Leucassin is used in other countries and is a more effective agent. It is also being tested for the treatment of hepatorenal syndrome. For varices, the purpose of these drugs is to constrict the blood vessels to stop the bleeding episode. Endoscopic procedures. Esophageal varices also may be managed with endoscopic variceal ligation, or EVL, banding. In some cases, Patients who cannot tolerate beta blocker preventative therapy may also have this treatment. This procedure involves the application of small O bands around the base of the varices to decrease the blood supply to the varices. The patient is unaware of the bands and they cause no discomfort. Endoscopic sclerotherapy, or EST, also called injection sclerotherapy, may be done to stop bleeding. The varices are injected with a sclerosing agent via a catheter. This procedure is associated with complications such as mucosal ulceration, which could result in further bleeding. Because of the lower potential for treatment-related side effects, EVL is preferred over EST. Transjugular intrahepatic portal systemic shunt. The transjugular intrahepatic portal systemic shunt, or TIPS, is a non-surgical procedure performed in interventional radiology departments. This procedure is used for patients who have not responded to other modalities for hemorrhage or long-term ascites. If time permits, patients have a Doppler ultrasound to assess vein anatomy and patency. The patient receives heavy IV sedation or moderate general anesthesia for this procedure. The radiologist places a large sheath through the jugular vein. A needle is guided through the sheath and pushed through the liver into the portal vein. A balloon enlarges this tract and a stent keeps it open. Most patients also have an ultrasound Doppler study of the liver after the TIPS procedure to record the blood flow through the shunt. Serious complications of TIPS are not common. Patients are discharged in 1 or 2 days and are followed up with ultrasounds for the first year after the shunt is placed. About 1/3 of them need to be reopened once during the first year as an ambulatory care procedure. Other interventions. Depending on the procedure done to control esophageal bleeding, patients may have a nasogastric tube inserted to detect any new bleeding episodes. Patients usually receive red-packed blood cells, fresh frozen plasma, isotopic saline, and platelets through large-bore IV catheters. Antibiotic therapy should be prescribed because a large number of patients who bleed develop an infection. Monitor vital signs every hour in coagulation studies, including PT and PTT, platelet count, and INR. Chart 61.2 lists additional interventions for patients at risk for bleeding. A small number of patients with cirrhosis bleed from gastric varices. Interventions for upper GI bleeding are discussed in Chapter 59. Potential for portal systemic encephalopathy. Planning expected outcomes. The patient is expected to be managed early to prevent this complication. However, if it occurs, it is expected that the interdisciplinary team will intervene early to prevent further health problems or death. Intervention. The mechanisms that cause portal systemic encephalopathy, or PS, are not completely clear, but ammonia probably plays a significant role. The poorly functioning liver cannot convert ammonia and other byproducts of metabolism to a less toxic form. They are carried by the circulatory system to the brain, where they affect cerebral function. The aim of PSC management is to halt this process. Because ammonia is formed in the GI tract by the action of the bacteria on protein, non-surgical treatment measures to decrease ammonia production include nutrition limitations and drug therapy to reduce bacterial breakdown. Collaborate with the nutritionist, pharmacist, and physician to plan and implement these interventions. Nutrition therapy. Patients with cirrhosis have increased nutritional requirements: high carbohydrate, moderate fat, and high protein foods. However, the diet is often changed for those who have elevated serum ammonia levels with signs of PSC. Patients should have a moderate amount of protein and fat and simple carbohydrates. Previously used protein restrictions are no longer required because patients need protein for healing. In collaboration with the nutritionist, be sure to include family members or significant others in nutrition counseling. The patient is often weak and unable to remember complicated guidelines. Brief, simple directions regarding dietary do's and don'ts are recommended. Keep in mind any financial, cultural, or personal preferences when discussing food choices, including the patient's food allergies. When a patient with cirrhosis has GI bleeding, it can result in the formation of increased amounts of ammonia as intestinal bacteria attempt to metabolize the blood cells. GI bleeding may lead to hepatic coma, stage 4 of PSE. Drug therapy. Drugs are used sparingly because they are difficult for the failing liver to metabolize. In particular, opioid analgesics, sedatives, and barbiturates should be restricted, especially for the patient with a history of encephalopathy. Encephalopathy. There. Several types of drugs, however, can eliminate or reduce ammonia levels in the body. These include lactulose, e.g. Evolose, Heptalic, or Lactolol, and non-absorbable antibiotics. So those eliminate or reduce ammonia levels in the body. The healthcare provider prescribes lactulose or lactolol, lactitol, to promote the excretion of ammonia in the stool. This drug is a viscous, sticky, sweet-tasting liquid that is given either orally or by an NG tube. The purpose is to obtain a laxative effect. Cleansing the bowels rids the intestinal tract of the toxins that contribute to encephalopathy. Whatever. It works by increasing osmotic pressure to draw One moment. Okay, it works by increasing osmotic pressure to draw fluid into the colon and prevents absorption of ammonia in the colon. The drug may be prescribed to the patient who has manifested signs of PSE, regardless of the stage. The desired effect of the drug is production of 2 or 3 soft stools per day and a decrease in patient confusion caused by PSE. Observed for a response to lactulose, the patient may report intestinal bloating and cramping. Serum ammonia levels may be monitored but do not always correlate with symptoms. Hypokalemia and dehydration may result from excessive stools. Remind unlicensed nursing personnel to help the patient with skin care if needed to prevent breakdown caused by excessive stools. Severe non-absorbable antibiotics may be given if lactulose does not help the patient meet the desired outcome or if he or she cannot tolerate the drug. These drugs should not be given together. Older drugs can become weak and older patients, adults can become weak and dehydrated from having multiple stools. Neomycin sulfate or microfidine, a broad-spectrum antibiotic, may be given to act as an intestinal antiseptic. It destroys the normal flora in the bowel, diminishing protein breakdown and decreasing the rate of ammonia production. Maintenance doses of neomycin are given orally but may also be administered as a retention enema. Long-term use has the potential for kidney toxicity and therefore it is not commonly used. It cannot be used for patients with existing kidney disease. Metronidazole or Flagyl or Novanidazole is another broad-spectrum antibiotic with similar action to neomycin, but it has less potential for renal toxicity. However, it should also be used for a short period of time and is therefore not commonly used. Rifaximin or Xifaxan seems to be the most effective and safest for long-term use, but it is not yet FDA approved for PSE. However, many healthcare providers have used it successfully for their patients. Frequently, assess for changes in level of consciousness and orientation. See Chart 61-2. Check for astrixis or liver flap and fetor hepaticus or liver breath. These signs suggest worsening encephalopathy. Yeah. Decision-making challenge, coordination of care. A 55-year-old cirrhotic patient is admitted to the general medical unit of the community hospital where you work with new onset dyspnea, possible pneumonia in open skin areas, and bruises on both arms. During his interview, you find out that he is taking aldactone, lactulose, and Corgard. He has had cirrhosis for at least 5 years, but continues to drink 12 beers every night. He is self-employed, and his 22-year-old daughter helps him in the office part-time. She tells you that she is very angry that he has continued to drink, even though he knows he is supposed to avoid alcohol. At times, he has been disoriented and had memory problems. 1. How should you respond to the patient's daughter? What laboratory findings do you expect will be abnormal in view of his diagnosis, and why? What is the priority for this man's care at this time? What interventions should you implement? And with what members of the interdisciplinary team should you collaborate to help the patient return home? Duh. Okay. Community-based care. If the patient with late-stage cirrhosis survives life-threatening complications, he or she is usually discharged to the home or to a long-term care facility after treatment measures have managed the acute medical problems. A home care referral may be needed if the patient is discharged to the home. These chronically ill patients are often readmitted multiple times, and community-based care is aimed at preventing rehospitalization. Some may have benefit from hospice. Collaborative care with the case manager, CM, or other discharge planner to coordinate interdisciplinary continuing care. Home care management. In collaboration with the patient, family, and CM, assess physical adaptations needed to prepare the patient's home for recovery. Referrals for physical therapy, nutrition therapy, and transportation for physician and laboratory follow-up may be needed. The patient's rest area needs to be close to a bathroom because diuretic and/or lactulose therapy increases the frequency of urination and stools. If the patient has difficulty reaching the toilet, additional equipment, e.g. bedside commode, is necessary. Special adult-size incontinence pads or briefs may be helpful if the patient has an altered mental status and has incontinence. If the patient has shortness of breath from massive ascites, elevating the head of the bed and maintaining the patient in a semi-fowler to high-fowler position may help alleviate respiratory distress. Alternatively, a reclining chair with a foot elevator may be used. Health teaching. The patient is discharged to the home setting with an individualized teaching plan, chart 61.3. That includes nutrition therapy, drug therapy, and alcohol abstinence. In collaboration with the nutritionist and in keeping with the patient's financial, cultural, and personal food preferences, provide information on eating a well-balanced diet. The patient with portal systemic encephalopathy, or PSE, often finds that small, frequent meals are best tolerated. If the patient's nutritional intake or albumin pre-albumin is decreased after discharge, multivitamin supplements and supplemental liquid feedings, e.g. Ensure and Boost, are usually needed. Teach patients to be careful with vitamins and minerals that can be toxic to the liver, such as megadose vitamin A, excessive iron supplements, and niacin. Remind them to check labels for those substances before taking any vitamin supplements. The patient is often discharged while receiving diuretics. Provide instructions regarding the healthcare provider's prescription for the diuretic. Teach about side effects of therapy, such as hypokalemia. The patient may need to take potassium supplement if he or she is taking a diuretic that is not potassium sparing. If the patient has had problems with bleeding from gastric ulcers, the provider may prescribe an H2 receptor antagonist agent or proton pump inhibitor to reduce acid reflux. Patients who have had episodic spontaneous bacterial peritonitis, or SBP, may be on daily maintenance antibiotic. Because some patients may have alienated relatives over the years because of substance abuse, it may be necessary to help them identify a friend, neighbor, or person in their recovery group for support. Patient and Family Education Guide, Cirrhosis, Nutrition Therapy. Consume a diet that adheres to the guidelines set by your physician, nurse, or nutritionist. If you have excessive fluid in your abdomen, follow the low-sodium diet prescribed for you. Eat small, frequent meals that are nutritionally well-balanced. Include in your diet daily supplemental liquids, e.g. Ensure or Ensure Plus, and a multivitamin. Drug therapy. Take the diuretics or preventive beta blocker prescribed for you. If you experience muscle weakness, irregular heartbeat, or lightheadedness, contact your healthcare provider right away. Take the medication prescribed for you that helps prevent gastrointestinal bleeding. Take the lactulose syrup as prescribed to maintain 2 or 3 bowel movements every day. Do not take any other medication prescribed or over the counter unless specifically prescribed by your healthcare provider. Alcohol abstinence. Do not consume any alcohol. Seek support services if needed. Teach family members about how to recognize signs of PSC and that, if necessary and safe, to increase the daily lactulose at the first sign of encephalopathy. The healthcare providers should also be contacted. Reinforce that constipation, bleeding, and infections may lead to PSC. Remind them that PSC is usually reversible. Advise the patient to avoid all over-the-counter drugs, especially NSAIDs and hepatic toxic herbs, vitamins, and minerals. Reinforce the need to keep appointments for follow-up medication care. Remind the patient and family to notify the physician immediately if any GI bleeding or overt bleeding or melena is noted, so that the reevaluation can be initiated quickly. One of the most important aspects of ongoing care is to stress the need to avoid alcohol and illicit drugs. See Chapter 8. By avoiding alcohol and drugs, the patient may prevent further fibrosis of the liver from scarring, allow the liver to heal and regenerate, prevent gastric and esophageal irritation, reduce the incidence of bleeding, and prevent other life-threatening complications. Healthcare resources. The patient with chronic cirrhosis may require a home care nurse for several visits after hospital discharge. The home care nurse can monitor the effectiveness of treatment in controlling acides. The encephalopathic patient may need to be monitored for adherence to drug therapy and alcohol abstinence. Individual and group therapy sessions may be arranged to assist patients in dealing with alcohol abstinence if they are too ill to attend a formal treatment program. If needed, refer to the patient and family to self-help groups such as Alcoholics Anonymous and Al-Anon. The patient may also desire spiritual support. Finances are frequently a problem for the chronically ill patient and family. Social support and community services need to be identified. The American Liver Foundation, liverfoundation.org, and American Gastroenterological Association, gastro.org, are excellent sources for more information about liver disease. For patients who are not candidates for liver transplantation, address end-of-life issues. Discuss options such as hospice care with patients and their families. Be aware that they will go through a grieving process and will perhaps be in denial or very angry. Evaluation outcomes. Evaluate the care of the patient with cirrhosis on the basis of the identified nursing diagnosis and collaborative problems. The expected outcomes include that the patient will have a decrease in or have no acides, have electrolytes within normal limits, WMNL, means within normal limits, not have hemorrhage or will be managed immediately if bleeding occurs, not develop PSC or will be managed immediately if PSC occurs, have the highest quality of life possible, and successfully abstain from alcohol or drugs if disease is caused by these substances. Specific indicators for these outcomes are listed for each nursing diagnosis and collaborative problem in the planning and implementation section seen earlier. Okay, on to hepatitis. Pathophysiology. Hepatitis is the widespread inflammation of liver cells. Viral hepatitis is the most common type and can be either acute or chronic. Less common types of hepatitis are caused by chemicals, drugs, and some herbs. This section discusses hepatitis caused by a virus. Viral hepatitis results from an infection caused by one of 5 major categories of viruses: hepatitis A, HAV, hepatitis B virus, HBV, hepatitis C, HCV, hepatitis D, HDV, and hepatitis E, guess what? EV. Some cases are viral hepatitis are not any of these viruses. These patients have non-AE hepatitis, or non-A through E hepatitis. Liver injury with inflammation can also develop after exposure. Excuse me. Liver injury with inflammation can also develop after exposure to a number of drugs and chemicals by inhalation, ingestion, or parenteral IV administration. Toxic and drug-induced hepatitis can result from exposure to hepatotoxins, e.g., industrial toxins, alcohol, and drugs. Hepatitis may also occur as a secondary infection during the course of infections with other viruses, such as Epstein-Barr, herpes simplex, varicella zoster, and cytomegalovirus. After the liver has been exposed to causative agents, e.g. a virus, it becomes enlarged and congested with inflammatory cells, lymphocytes, and fluid, resulting in right upper quadrant pain and discomfort. As the disease progresses, the liver's normal lobular pattern becomes distorted as a result of widespread inflammation, necrosis, and hepatocellular regeneration. This distortion increases pressure within the portal circulation, interfering with the blood flow into the hepatic lobules. Edema of the liver's bile channels results in obstructive jaundice, or a yellowing of the skin. Classification of hepatitis and etiologies. The 5 major types of acute viral hepatitis vary by mode of transmission, manner of onset, and incubation periods. Hepatitis cases must be reported to the local public health department, which then notifies the Centers for Disease Control and Prevention, CDC. Hepatitis A. The causative agent of hepatitis A virus, HAV, is a ribonucleic acid RNA virus of the enterovirus family. It is a hardy virus and survives on human hands. The virus is resistant to detergents and acids, but is destroyed by chlorine or bleach and a temperature greater than 195 degrees Fahrenheit. HAV usually has a mild course similar to that of a typical flu-like infection and often goes unrecognized. It is spread via the fecal-oral route by fecal contamination, either from person-to-person contact, e.g. oral anal sexual activity, or by consuming contaminated food or water. Common sources of infection include shellfish caught in contaminated water and food contaminated by food handlers infected with HAV. The incubation period of hepatitis A is usually 15 to 50 days, with a peak of 25 to 30 days. The disease is usually not life-threatening, but its course may be more severe in people older than 40 years and those with pre-existing liver disease, such as hepatitis C. Table 61.5. Examples of extrahepatic manifestations of hepatitis A. Neurologic findings: post-viral encephalitis, Guillain-Barré syndrome, and transverse myelitis. Hematologic findings would be aplastic anemia, autoimmune hemolysis, and anemia. And then renal findings would be acute tubular necrosis, ATN, and nephrotic syndrome. Gastrointestinal findings would be pancreatitis and acalculous cholecystitis. Acalculous, not calculus. Other findings would be reactive arthritis and cutaneous vasculitis. In a small percentage of HAV cases, the severe illness with extrahepatic manifestations can occur. Table 61.5. Advanced age and conditions such as chronic liver disease may cause widespread damage that requires a liver transplant. In some cases, death may occur from HAV. The incidence of hepatitis A is particularly high in non-affluent countries in which sanitation is poor. Children are affected the most, and many of them do not have symptoms. Some adults have hepatitis A and do not know it. The course is similar to that of a GI illness, and the disease and recovery are usually uneventful. Hepatitis B. The hepatitis B virus is transmitted like HIV. It is a double-shelled particle containing DNA composed of a core antigen called HBCAG, a surface antigen, HBsAg, the core antigen is HBcAg for core, and the surface antigen is HBsAg for surface, and another antigen found within the core called HBeAg that circulates in the blood. HBV may be spread through these common modes of transmission: unprotected sexual intercourse with an infected partner, sharing needles, accidental needle sticks or injuries, that's the blood, from sharp instruments, primarily in healthcare workers, low incidence, blood transfusions that have not been screened for the virus before 1992, hemodialysis, maternal fetal route, more common in Asia. The clinical course of hepatitis B may be varied. Symptoms usually occur within 25 to 180 days of exposure and include anorexia, nausea and vomiting, fever, fatigue, right upper quadrant pain, dark urine with light stool, joint pain, and jaundice. Blood tests confirm the disease, although many people with hepatitis B have no symptoms. Most adults who get hepatitis B recover, clear the virus from their body, and develop immunity. However, a small percentage of people do not develop immunity and become carriers. Hepatitis carriers can infect others even though they are not sick and have no obvious signs of hepatitis B. Chronic carriers are at high risk for cirrhosis and liver cancer. Because of the high number of newcomers from endemic areas, the incidence of hepatitis B has increased in the United States. Hepatitis C. The causative virus of hepatitis C, HCV, is an enveloped single-stranded RNA virus. The transmission is blood to blood. The rate of sexual transmission is very low in a single couple relationship but increases with multiple sex partners. HCV is spread most commonly by illicit IV drug needle sharing, that's the highest incidence, and blood products or organ transplant received before 1992. Needle stick injury from HCV contaminated blood, healthcare workers at high risk, unsanitary tattoo equipment, sharing of intranasal cocaine paraphernalia. The disease is not transmitted by casual contact or by intimate household contact. However, those infected are advised not to share razors, toothbrushes, or pierced earrings because microscopic blood may be on these items. The average incubation period is 7 weeks. Acute infection and illness are not common. Most people are completely unaware that they have been infected. They are asymptomatic and not diagnosed until many months or years after the initial exposure, when an abnormality is detected during a routine laboratory evaluation or when liver problems occur. Unlike with hepatitis B, most people infected with hepatitis C do not clear the virus and a chronic infection develops. HCV usually does its damage over decades by causing a chronic inflammation in the liver that eventually causes the liver cells to scar. This scarring may progress to cirrhosis. Alcohol use increases the progression and severity of cirrhosis. Hepatitis C induced cirrhosis is the leading indication for liver transplantation in the United States. Unfortunately, the newly transplanted liver often becomes reinfected with the virus. Damn. Hepatitis D. Hepatitis D, delta hepatitis, or HDV, is caused by a defective RNA virus that needs the helper function of HBV. It occurs only with HBV to cause viral replication. This usually develops into chronic HDV. The incubation period is about 14 to 56 days, as with HBV. The disease is transmitted primarily by parenteral routes, especially patients who are IV drug users. Having sexual contact with a person with HDV is also a high risk factor. Hepatitis E. The hepatitis E virus, HEV, is a waterborne infection associated with epidemics of hepatitis in the Indian subcontinent, Asia, Africa, and Middle East, Mexico, and Central and South America. Many large outbreaks have occurred after heavy rains and flooding. Like hepatitis A, HEV is caused by fecal contamination of food and water. In the United States, hepatitis E has been found only in international travelers. It is transmitted via the fecal-oral route, and the clinical course resembles that of hepatitis A. HEV has an incubation period of 15 to 64 days. There is no evidence at this time of a chronic form of HEV. The disease tends to be self-limiting and resolves on its own. Complications of hepatitis. Failure of the liver cells to regenerate with progression of the necrotic process results in a severe acute and often fatal form of hepatitis known as fulminant hepatitis. Hepatitis is considered to be chronic when liver inflammation lasts longer than 6 months. So that's the acute version, often fatal. That's because of failure of liver cells to regenerate with the progression of the necrotic process. Okay, chronic hepatitis usually occurs as a result of hepatitis B or C. Superimposed infection with hepatitis D in patients with chronic HBV may also result in chronic hepatitis. Chronic hepatitis can lead to cirrhosis and liver cancer. Incidence/prevalence. The incidence of hepatitis A and hepatitis B is declining as a result of CDC recommendations for vaccination. However, hepatitis B and hepatitis C are concerned because of their association with cirrhosis and liver cancer. Although exact numbers are not known, it is estimated that about 200 million people worldwide have the hepatitis C virus, making this type of hepatitis the most common type. Currently, there is no vaccine for HCV. Therefore, it is expected that the cases of HCV will rise over the next several decades as a result of increasing illicit drug use. This increase will require a major increase in transplantations and lead to many more deaths. Health promotion and maintenance. Hepatitis vaccines for infants, children, and adolescents have helped decrease the incidence of hepatitis A and B. Some adults are also advised to receive these immunizations. Measures for preventing hepatitis A in adults include proper hand washing, especially after handling shellfish, avoiding contaminated foods or water, including tap water in countries with high incidence, receiving immune globulin within 14 days if exposed to virus, receiving the HAV vaccine before traveling to areas where the disease is common, e.g. Mexico and the Caribbean, receiving the vaccine if living or working in enclosed areas with others such as college dormitories, correctional institutions, daycare centers, and long-term care facilities. 2 HAV vaccines are available, Havrix and Vacta. Both are made of inactive hepatitis A virus and are given in the deltoid muscle. For hepatitis B, HBV prevention, a vaccine can also provide protection against the disease. 2 vaccines, Energix B and Recombavax HB, are available. Twinrix is a combination of HAV and HBV vaccine, and that is also available for adults. Immunization against HBV should be used for people who have unprotected sexual intercourse with more than one partner, men having sex with men, MSM is the abbreviation for men having sex with men, people with any chronic liver disease, such as hepatitis C or cirrhosis, people who are exposed to blood or body fluids in the workplace, including healthcare workers, firefighters, and police. Additional measures to prevent viral hepatitis for healthcare workers and others in contact with infected patients are listed in Chart 61.4 and 61.5. Patient-centered collaborative care assessment history. Begin by asking the patient whether he or she has had known exposure to a person with hepatitis. For the patient who presents with few or no symptoms of liver disease but has abnormal laboratory tests, e.g., elevated alanine aminotransferase or ALT or aspirate aminotransferase AST levels, the history may need to include additional questions regarding risk factors such as exposure to either inhaled or ingested chemical, use of herbal supplement, use of any new prescribed medication or over-the-counter OTC medication, recent ingestion of shellfish, exposure to a possibly contaminated water source, travel to another country. Chart 61.4, best practice for patient safety and quality care, prevention of viral hepatitis in healthcare workers. Listen closely. Use standard precautions to prevent the transmission of disease between patients or between patients and healthcare staff. See Chapter 25. Eliminate needles and other sharp instruments by substituting needleless systems. Needle sticks are the major source of hepatitis B transmission in healthcare workers. Take the hepatitis B vaccine, e.g. Recombivavax HV, which is given in a series of 3 injections. This vaccine also prevents hepatitis D by preventing HBV. For post-exposure prevention of hepatitis A, seek medical attention immediately for immunoglobulin IG administration. That's post-exposure. Report all cases of hepatitis to the local health department. Chart 61.5, Patient and Family Education Guide. Health practices to prevent viral hepatitis. Maintain adequate sanitation and personal hygiene. Wash your hands before eating and after using the toilet. Drink water treated by a water purification system. If traveling in undeveloped or non-industrialized countries, drink only bottled water. Avoid food washed or prepared with tap water, such as raw vegetables, fruits, and soups. Avoid ice. Use adequate sanitation practices to prevent the spread of the disease among family members. Do not share bed linens, towels, eating utensils, or drinking glasses. Do not share needles for infection, body piercing, or tattooing. Do not share razors, nail clippers, toothbrushes, or water picks. Use a condom during sexual intercourse or abstain from this activity. Cover cuts or sores with bandages. If ever affected with hepatitis, never donate blood, body organs, or other body tissue. Sexual activity with men or women or both, and this is back to the text. And this is a list of, a list of risk factors, things that you ask about when you're doing a history on someone. Okay, sexual activities with men, women, or both, and whether it was protected or unprotected, illicit drug use, IV or intranasal, for healthcare workers, recent needle stick exposure, body piercing or tattooing, close living accommodations such as military barracks, correctional institutions and overcrowded dormitories, long-term care facilities, daycare centers, or employment in any such setting. Blood or blood products or organ transplants received before 1992, military service, place of birth, United States or other country, and parents' place of birth, history of alcohol use, how many drinks each day, a week, human immune HIV. Okay, physical assessment / clinical manifestations. Assess whether the patient has abdominal pain, changes in skin or sclera, arthralgia or joint pain, or myalgia or muscle pain, diarrhea / constipation, changes in color of urine or stool, fever, lethargy, malaise, nausea and vomiting, pruritus, itching. Lightly palpate the upper or the right upper abdominal quadrant to assess for liver tenderness. The patient may report right upper quadrant pain with jarring movements. Inspect the skin, sclera, and mucous membranes for jaundice. He or she may present for medical treatment only after jaundice appears, believing that other vague symptoms are related to an influenza-like syndrome. Jaundice in hepatitis results from intrahepatic obstruction and is caused by edema of the liver's bile channels. Dark urine and clay-colored stools are often reported by the patient. If possible, obtain a urine and stool specimen for visual inspection and laboratory analysis. The patient may also have skin abrasions from pruritus and itching. Psychosocial assessment. Viral hepatitis has various presentations, but for most infected people, the initial course is mild with few symptoms. The long-term complications of fibrosis and cirrhosis cause the more serious problem. This is especially true for patients who have chronic HBV and HCV. Emotional problems for affected patients may center on feeling sick and fatigued. General malaise, inactivity, and vague symptoms contribute to depression. Some patients often feel guilty and are remorseful about decisions made that caused the disease. These feelings are most likely to occur when the source of infection is from drug abuse. Family members may be angry that the patient caused the disease. Infectious diseases such as hepatitis continue to have a social stigma. The patient may feel embarrassed by the precautions that are imposed in the hospital and continue to be necessary at home. This embarrassment may cause the patient to limit social interactions. Patients may be afraid that they will spread the virus to family and friends. Family members are sometimes afraid of getting the disease and may distance themselves from the patient. Allow them to verbalize these feelings and explore the reasons for these fears. Educate the patient and family members about modes of transmission and clarify information as needed. Patients may be unable to return to work for several weeks during the acute phases of illness. The loss of wages and the cost of hospitalization for a patient without insurance coverage may produce great anxiety and financial burden. This situation may last for months or years if hepatitis becomes chronic. Laboratory assessment. Hepatitis A, hepatitis B, and hepatitis C are usually confirmed by acute elevations in levels of liver enzymes, indicating liver cellular damage, and by specific serologic markers. Levels of ALT and AST levels may possibly rise into the thousands in acute or fulminant cases of hepatitis. Alkaline phosphatase levels may be normal or elevated. Serum total bilirubin levels are elevated and are consistent with the clinical appearance of jaundice. Elevated levels of bilirubin are also present in the urine. The presence of hepatitis A is established when hepatitis A virus antibodies, anti-HAV, are found in the blood. Ongoing inflammation of the liver by HAV is indicated by the presence of immunoglobulin, or IgM, antibodies, which persist in the blood for 4 to 6 weeks. Previous infection is identified by the presence of immunoglobulin G, or IgG, antibodies. These antibodies persist in the serum and provide permanent immunity to HAV. The presence of the hepatitis B virus is established when serologic testing confirms the presence of hepatitis B antigen antibody systems in the blood and a detectable viral count, HBV polymerase chain reaction, or PCR DNA. Antigens located on the surface or shell of the virus, HBsAg, and IgM antibodies to hepatitis B core antigen anti-HBc IgM are the most significant serologic markers. The presence of these markers establishes the diagnosis of hepatitis B. The patient is infectious as long as HBsAg hepatitis B surface antigen is present in the blood. Good to know. Persistence of this serologic marker after 6 months or longer indicates a carrier state or chronic hepatitis. HBsAg levels normally decline and disappear after the acute hepatitis B episode. The presence of antibodies to hepatitis B surface and antibody or HBsAg, the presence of antibodies to hepatitis B surface antibody HBsAb in the blood indicates recovery and immunity to hepatitis B. People who have been vaccinated against HBV have a positive HBsAb because they also have immunity to the disease. So that's what you need to get. Enzyme-linked immunosorbent assay, or ELISA, is the initial screening test for patients suspected of being infected with hepatitis C virus. It is also the most commonly used enzyme test for HCV antibodies, anti-CV. HCV. The antibodies can be detected within 4 weeks of the infection. A more specific assay called the recombinant immunoblot assay, or REBA, has been used as a confirmatory test. These tests show that the patient has been exposed to HCV and has developed the antibody. To identify the actual circulating virus, the HCV PCR-RNA test is used. This confirms active virus and can measure the viral load. The hepatitis D virus, or HDV, can be confirmed by the identification of intrahepatic delta antigen, or more often by a rise in the hepatitis D virus antibodies anti-HDV titer. This increase can be seen within a few days of infection. Hepatitis E virus, HEV, testing is usually reserved for travelers in whom hepatitis E is present but the virus cannot be detected. Hepatitis E antibodies, anti-HEV, are found in people infected with the virus. Other diagnostic assessment. Liver biopsy may be used to confirm the diagnosis of hepatitis and to establish the stage and grade of liver damage. Characteristic changes help the pathologist distinguish among a virus, drug, toxin, fatty liver, iron, and other disease. It is usually performed in an ambulatory care setting as a percutaneous procedure through the skin after a local anesthetic is given. If coagulation is abnormal, however, it may be done using either a CT-guided or a transjugular route to reduce the risk of pneumothorax or hemothorax. Ultrasound may also be used. Interventions. The patient with viral hepatitis can be mildly or acutely ill depending on severity of the inflammation. Most patients are not hospitalized, although older adults and those with dehydration may be admitted for a short-term stay. The plan of care for all patients with viral hepatitis is based on measures to rest the liver, promote cellular regeneration, and prevent complications, if possible. During the acute stage of viral hepatitis, interventions are aimed at resting the inflamed liver to promote hepatic cell regeneration. Rest is an essential intervention to reduce the liver's metabolic demands and increase its blood supply. Collaborative care is generally supportive. The patient is usually tired and expresses feelings of general malaise. Complete bed rest is usually not required, but rest periods alternating with periods of activity are indicated and are often enough to promote hepatic healing. Individualize the patient's plan of care and change it as needed to reflect the severity of symptoms, fatigue, and results of liver function tests and enzyme determinations. Activities such as self-care and ambulating are gradually added to the activity schedule as tolerated. The diet should be high in carbohydrates and calories with moderate amounts of fat and protein after nausea and anorexia subside. Small, frequent meals are often preferable to 3 standard meals. Ask the patient about food preferences because favorite foods are tolerated better than randomly selected foods. Encourage the patient to eat foods that are appealing. High-calorie snacks may be needed. Supplemental vitamins are often prescribed. Drugs of any kind are used sparingly for patients with hepatitis to allow the liver to rest. An antiemetic to relieve nausea may be prescribed. There is no approved drug that is used to treat HAV. The patients with chronic hepatitis B and hepatitis C, a number of drugs are given, including antiviral and immunomodulating drugs. Antiviral drugs that may be used for HBV include lamivudine or Epivar HBV, entecavir or Baraclude, and talbividune or Tizeca. Also, adaforvir, Dipivozil, or Hepsera. Teach patients taking these drugs to report any muscle weakness or aching because they can cause myopathy. Pegylated interferon alpha 2b or PEG-intron is given to reduce the replication of the HBV in patients with chronic disease and increase immunity. It is now available in a pen injection device. All the drugs used for HBV can cause renal toxicity. The current standard of care for hepatitis C is a combination of subcutaneous pegylated interferon alpha once a week and oral ribavirin or Copagus or Rebitol daily. Ribavirin should never be given to a pregnant patient. Women of childbearing age must agree to use contraception if they are receiving treatment, if they are sexual partners of patients taking this drug. The length of treatment depends on genotype or strain of hepatitis. There are several different genotypes. Most Americans who have hepatitis C are genotype 1. This genotype usually requires 48 weeks of treatment. Genotypes 2 and 3 have a better response rate if the viral load is low and usually need only 24 weeks of treatment. Genotypes 4 and 5 are typically treated for 48 weeks. The desired outcome of treatment is to have a negative HCV PCR RNA level and to sustain a negative level after treatment has ended. The secondary expected outcome is improvement in liver function. Response rates vary, but adults who are young, have a low viral load, and have minimal scarring on liver biopsy have a better chance of clearing the virus and remaining free of hepatitis C after treatment has ended. NCLEX examination challenge. An older adult is hospitalized with severe dehydration and hepatitis A. What precautions should the nurse use when caring for this client? Select all that apply. A. Gloves. B. Masks. C. Gowns. D. Shoe covers. E. Goggles. F. Hand washing. Community-based care. Home care management varies according to the type of hepatitis and whether the disease is acute or chronic. A primary focus in any case is preventing the spread of infection. For hepatitis transmitted by fecal-oral route, careful hand washing and sanitary disposal of feces are important. Standard precautions are used for hepatitis transmitted percutaneously and mucosally. Education is therefore very important. Collaborate with the certified infection control practitioner and infectious disease specialist if needed in caring for these patients. These experts can also suggest resources for the patient and family. Teach the patient and the family to use measures to prevent infection transmission. See Chart 61.5. In addition, instruct the patient to avoid alcohol and to check with the healthcare provider before taking any medications or vitamin supplement or herbal preparation. Encourage the patient to increase activity gradually to prevent fatigue. Suggest that he or she eat small, frequent meals or of high carbohydrate foods. Chart 61.6. And that was hepatitis.